Hello everyone, once again I am Dr. Arun Swami, your physiology faculty. So in this video we are going to be talk about the ECG in a very short manner so that in your examination you can easily identify and you can easily answer all such questions related from the ECG. In this session we will discuss about the high yield area with fast concept and with ECG MCQs and with image based questions, right guys? So let's start this ECG short revision. So talking about the ECG basics, you should know first of all the P wave. This is for atrial depolarization. The QRS complex, this is for ventricular depolarization. The T wave, this is for ventricular repolarization. Atrial repolarization, if we talk about, this actually hidden inside the QRS. And as we know that ventricles are very important for us, hence we'll never talk about the atrial repolarization part. We were very much concerned only with the ventricular depolarization and repolarization, which is actually your QRS and the T wave. Also, please remember the normal values. The rate. First of all, the heart rate is always between 60 to 100. So guys, first of all, the first thing which most of the student, they basically do this mistake, that whenever the heart rate is less than 60, then only we'll call it as a bradycardia. And whenever the heart rate is more than 100, we always call it as a tachycardia. Until unless if heart rate is suppose 95, 99, guys, this is absolutely normal heart rate. This is not the tachycardia. Similarly, if the heart rate is 61, 65, this is absolutely normal. This is not the bradycardia. After that, the PR interval. This PR normal value is 0.1 to 0.20 second. If PR interval is shortened, then this is indicates the WPW syndrome, and if PR interval is prolonged, this is indicates the heart block. Always remember, guys, this is similarly with 3 to 5 small squares. The QRS, the duration of the normal QRS complex, this is less than 0.12 second. QT interval duration in males, it is less than 440 millisecond, and in females it is less than 460 millisecond. The paper speed, the ECG paper speed, which is actually we are checking on the ECG machine. So the speed of this ECG paper is 25 mm per second. And the one small square, the time duration which is taken by the machine to cover the one small square, this is 0.04 second. If it will convert into the millisecond, it will come into the 40 millisecond. Very important. Also remember the size of one small box, it is 1 by 1 mm. How much? 1 by 1 mm. Very important. Then talking about the MI leads and the vessels. Guys, please pay attention that MI is very favorite topic for various examination for the examiner. So guys, you should always remember that's different leads which is can showing the different wall of the MI. So number one, that is your inferior wall MI. Guys, the inferior wall MI, as we know, the leads which is most commonly involved, that is 2-3 AVF. So the ST elevation you will see in the 2-3 AVF lead. And which vessel is most common in inferior wall MI? That is right coronary artery. Very important, right coronary artery. Similarly, for the septal wall, this is your V1, V2. So the septal wall, V1, V2 lead will be involved. In anterior wall, this is V3, V4. That is your interior wall. And the most common artery which is involved in the anterior wall MI, that is LAD, left anterior descending artery. Similarly, for the lateral wall, this is your V5 and the V6. Guys, V5, V6, similarly AVL and lead 1. This is correspond to the lateral wall of MI, and the most common artery which is involved in this condition, that is left circumflex artery. So this is most favorite area. Examiner may give you the ECG and may ask you that which wall of MI is that. Okay, so always remember. The next is ST and the T changes. Guys, ST elevation and ST depression, or the T inversion or the T elevation, where it could be seen. Guys, please pay attention. The ST elevation. ST elevation is defined for the acute injury, that is STEMI, ST elevation myocardial infarct. And ST depression is defined the ischemia or reciprocal changes. So guys, if the ST is going upside, this is showing acute MI, but if ST depression is there, this will show you the ischemia. T wave inversion, this is also showing the ischemia, and T wave is going to be upward, means there is a hyperacute. This could be seen in hyperkalemia. Guys, please pay attention. The pathological Q wave. The pathological Q wave is defined the old infarct, right? Old infarct. Okay. So this is how you have to be easily understand and easily remember with related the ST and the T wave, right? Very, very important. The next part is blocks and the bundle branch block. Guys, please pay attention that the first degree AV block, this is when the PR is more than 0.20 second. Mobitz type 1 and type 2, this is second degree heart block. So this Mobitz type 1 and type 2 is Mobitz type 1, this is Wenckebach, PR gradually prolonged and then there is a drop beat. But in Mobitz type 2, the PR is fixed and normal with drop beat is there, right? Drop beat is there. So this is Mobitz type 1 and Mobitz type 2. And the complete AV block, guys, the complete AV block, that is your irregular pattern between P and QRS. Means there is no significance between the P and the QRS. Ideally, first of all, the P wave should become, then the QRS should become, and then the T wave. But suppose if this P can comes after the QRS, QRS can come with the P, means anybody can come at any time. This is we call as complete AV block or the third degree heart block. Very, very important, this blocks, right guys? Please pay attention. If you'll see in the ECG, you should remember in the first degree heart block, as just now we discussed, PR is prolonged with no drop beat. So you can see over here, PR is constantly prolonged. PR is constantly prolonged, but all the time QRS is forming, means no drop beat is there. That is first degree heart block. Then number 2 is second degree type 1, that is Wenckebach. PR gradually prolonged and then there is a drop beat. So this is normal PR, PR little bit prolonged, more prolonged, and then there is a drop beat. This is will tell us about the type 1, that is second degree type 1, Mobitz type 1. In type 2, we know the PR is constant. PR is constant and there is a drop beat. So you can see PR normal, and then there is a drop beat, means no QRS formation. Again there is a PR normal, and again there is a drop beat. So this is tell us about the second degree Mobitz type 2. And then there is the third degree, means the complete heart block. You can see that P is coming with the T. This P is merged inside of this QRS. So anytime P can come after the QRS, P can come with the T, with the QRS, or before the QRS. Anytime if this pattern could be seen, this is correspond to the third degree AV block, third degree heart block. Very, very important part. You should always have to be remember. Then talking about the electrolyte, guys, the electrolytes can also change the ECGs, right? So you should be very much careful with that. See, the blood supply can change the ECGs and the electrolyte balance can change the ECGs. So now, earlier we discussed about the blood supply that we have been discussed in the MI, and also that heart conduction, means the current passing through area can change the ECG. So that's we discussed in the conduction part. Now, how the electrolyte can change the ECG. Hyperkalemia, it will show you the tall peak T wave with wide QRS, and there will be a sine wave like this sine wave, right? So this is showing you sine wave like this pattern. And then the hypokalemia, there will be the flat prominent U wave, hypocalcemia, prolonged QT, and hypercalcemia, short QT. Guys, always remember QT is always inversely proportional to the calcium, right? Inversely proportional to the calcium. Very, very important part. So guys, sometimes most of the student gets confusion, sir, which is the normal QT, which is the prolonged QT. Guys, the prolonged QT and the QT normal, you can see over here, this QT interval starts from beginning of the Q and end of the T. One more time, it starts from beginning of the Q and end of the T, that is your QT. interval, and this QT interval is actually, guys, defining with the ventricular activity, that is atrial, that is ventricular depolarization and the ventricular repolarization, and this complete area we call as QT interval. Guys, whenever this QT, you can see over here, this QT is that much, here the QT is prolonged. Guys, this is the condition which we call as long QT, right? Long QT, right? So this is the different areas how you can identify all of this such ECGs in the MCQs. Then talking about the arrhythmia, means the irregular heart rate. The one-liners you should be remember about the arrhythmias. Atrial fibrillation, there will be the irregular, no P wave could be seen. The rhythm could be irregular with no P wave. In atrial flutter, there will be the sawtooth pattern, and there is the ratio of 2:1, right? 2:1. Heart rate will be more than 150. And in supraventricular tachycardia, there is the regular narrow QRS tachycardia and P will be hidden. And in ventricular tachycardia, guys, the regular wide QRS tachycardia. And guys, all the time, please mark this point. If you will seeing that there is a wide QRS in the MCQ, guys, until unless nothing is proven, guys, always just go with the ventricular tachycardia option all the time. Please follow this rule. You will never do this mistake during the solving the MCQs, guys. That is very important. In torsades, there will be the polymorphic ventricular tachycardia and there will be the prolonged QT, right? So one more time, atrial fibrillation, irregular rhythm, absent P wave. Atrial flutter, sawtooth pattern. SVT, regular narrow QRS. Ventricular tachycardia, regular wide QRS. And polymorphic ventricular tachycardia, torsades, right? Torsades. So irregular, no P wave. If you will see in the MCQs, guys, you can easily go with the option that is your atrial fibrillation. तो अगर आपको बेटा MCQ के अंदर मिले कोई P wave नहीं है, no P wave is there, irregular rhythm means how you have to be calculate. This is your R, this is R, this is R, this is R, this is R. The regular rhythm should have the distance of RR interval should be equal. That we called as regular rhythm, but you can see the distance of RR is unequal. Here it is this much, here it is this much, but here it is prolonged, here it is again shortened, more shortened. So you can see the RR interval is different. That is we called as regularly irregular rhythm, right guys? Irregular rhythm. Now guys, please pay attention that whenever we'll talk about the normal ECG, you can see over here, this is your R, this is your R, this is the another R, this is the another R. All the time before the R, there is the P wave. All the time there is the P wave, right? Can you appreciate this part? So you can see the distance between RR is equal, that is equal. And if this is equal, this is we called as regular rhythm. What we call this? Regular rhythm. Here you can see no identifiable P wave, absent P wave, no identifiable P wave before the R, and RR is also unequal. That we called as irregular rhythm, right? And this is the answer which you have to be marked whenever you'll see this condition, atrial fibrillation. So in MCQ, if you'll see guys, irregular with no P wave, go with immediately atrial fibrillation. Then talking about the sawtooth wave, regular rhythm and rate is around 150 per minute if the given in the option. Guys, immediately mark the atrial flutter. Guys, how the sawtooth pattern? The sawtooth pattern, you can see over here that 3 P wave is coming. The 3 P wave is coming and 1 QRS is coming. 3 P wave is coming and 1 QRS is coming. 3 P wave is coming, 1 QRS is coming. So guys, how you can see over here? You can see guys, this is looking like a tooth. This is looking like a tooth. This we call as sawtooth pattern, right? So this is how, if you will see that there is regular rhythm, means the distance of RR is equal. You can see every time RR is equal. This is regular rhythm, but sawtooth pattern. Guys, immediately you should mark in the MCQ, that is your atrial flutter, right? So one more time, if you will see irregular, no P wave, atrial fibrillation. If you will see sawtooth wave, regular rhythm, that is atrial flutter, right? Now the narrow QRS, Just now we discussed narrow QRS. This QRS you can see, this is very much narrow over here. This narrow QRS and rate is given more, that is around 180 per minute, guys. This is the example of SVT, supraventricular tachycardia, right? So narrow QRS jab bhi mile, mark that SVT, right? SVT. And wide QRS, mark the VT, right? Wide QRS, mark the VT. So you can see that QRS is completely broader, right? Wider. This is the example of ventricular tachycardia. So guys, please remember the two things. Short QRS, go with the SVT. Wide QRS, go with the VT. No P wave and irregular rhythm, atrial fibrillation. Sawtooth pattern, atrial flutter. Right now, coming to the next, prolonged QT, polyphormic ventricular tachycardia. If given in the MCQ, guys, always go with the answer with torsade de pointes. Until unless anything is not proven, guys, go with the torsade de pointes. What is the polyphormic ventricular tachycardia? There is a twisting like wave is seen in over here. So you can see this is a twisting like wave is seen over here, and this is called as polymorphic ventricular tachycardia. Ideally, it should be come always like this, right, in the same level, but you can see this is like a dancing over here. This is dancing over here like this. This is called as polyphormic ventricular tachycardia. So jab bhi ye dikhe, immediately go with the torsade de pointes. So one more time, no P wave, irregularly regular rhythm, atrial fibrillation. Sawtooth pattern, atrial flutter. Short QRS, SVT. Wide QRS, VT. This dancing like QRS or dancing like wave, polyphormic ventricular tachycardia, prolonged QT, that is torsade de pointes, right? Then talking about the ST elevation. ST elevation is correspond with the MI, right? And we know, guys, we have to identify in the leads which wall is MI. So this is as given in the option ST elevation, or if the option is given about the 2-3 AVF, or given that with the ECG image, guys, you can see the ST elevation if it is given in the 2-3 AVF. Where is the 2? This is the lead number 2. You can see this ST elevation, right? 3, this is ST elevation, right? And AVF, guys, this is your AVF. Here again you can see the ST elevation. If this is the given, guys, this will correspond to the inferior wall MI, right? Mark with the inferior wall MI. So I hope you can easily appreciate with this part that here is ST elevation in 2-3 AVF. As you can see in the ECG, marked with the inferior wall MI. If ST elevation is given in V1, V2, V3, V4, as you can see that this is V1, V2, V3, and this is your V4, guys, right? V4. So you can see everywhere this is your ST elevation, right? And this is significant for anterior wall MI, right? Anterior wall MI. You can see over here in 2-3 AVF. In 2-3 AVF, everything is normal. But earlier there was the ST elevation, right? So if ST elevation in 2-3 AVF, inferior wall MI, V1 to V4, anterior wall MI or anteroseptal wall MI, and in the ST elevation in V5, V6 or AVL and 1 lead, guys, this is correspond to the lateral wall MI, right? Lateral wall MI. So you can see over here that in V5, V6, this is V5, V6, and then your AVL. This is your AVL, guys. You can see that clearly. You can appreciate over that this is your ST elevation, and in lead number 1 again you can easily appreciate this is the ST elevation. So this is ST elevation, this is ST elevation, this slight ST elevation you can see over here, this is correspond to the lateral wall MI, right, guys? Lateral wall MI. Then talking about the T wave, narrow, peaked, tented, or the symmetrical without ST depression. If given in the option and asking that what is the main cause, guys, always go with the hyperkalemia, right? hyperkalemia. Very, very important. So sometimes students get confused, sir, what is the normality, what is the hyperacute, or in hyperkalemia, how it could be seen. So you can see over here that if the QRS is forming like this is the QRS, right guys? ये बेटा QRS दिख रहा है आपको? So you can see this is your QRS and this is your T. It is almost up to the level or little bit going to upside. But if you can see in this part, the QRS is ending over here and T is going very much at height, guys. This is called as hyperacute ischemia. This is hyperacute T wave, right? This is symmetric, broad based, not tented, not pointed, right? So this is QT intervals tends to be long, right? Now please pay attention that in hyperkalemia, how it could be looks like. Again, the QRS is ending over here. QRS is ending over here, but you can see that this is making like a point over here. It is doing like this. It is not making that much of point. It is doing something like this. But here you can see it is making a point like this, right? This is point. So this is symmetric, narrow based and pointed tenting, guys. If this is, you can see, guys, always go with the hyperkalemia. So you can immediately you can see over here, this is making like a notch. ये बहुत तीखी है, but this is little bit blunt, right? This is little bit blunt. So this is hyperacute, that is seen in hyperacute ischemia. Now the T wave inversion. If talking about the T wave inversion, as we already discussed, T wave inversion is due to ischemia, myocardial ischemia. So guys, here you can see this T wave. This T wave is going towards the downside. Everywhere T wave is going towards the downside, guys. This is we call as T wave inversion, and this T wave inversion correspond to the myocardial ischemia, right? So the various type of T wave you should know to answer such questions, guys. This is your QRS complex, and this is your T wave, that is normal. If this is your QRS complex and you can see the T is moving towards the downside, this is called as inverted. This is making a point like condition over here. This is we called as peak T wave. If this is looking like a flat, this is we call as flattened T wave. And if this is making like a sign over here, guys, this is we call as bifid T wave, right? Bifid T wave. So these are the different type of T wave which you should identify whenever you are seeing any type of ECG. So guys, in the last minute, the last checklist for the ECG, all the time, whenever you'll see any ECG MCQ, guys, go with that sequence. What is the sequence? Sequence is, first of all, check the rate, see the rhythm, axis, PR, QRS, STT, and the QT, and then go with the diagnosis. All the time, you will never make any mistake. अगर आपने इस चीज को बेटा इस तरीके से follow कर लिया कि all the time when you will see the ECG, the sequence to read the ECG is always check the rate, check the rhythm, check the axis, then PR, then QRS, then STT, and then the QT, and then your diagnosis. Always remember the one thing, always correlate the symptoms, whatever is given in the MCQs. Check the vitals and see the electrolyte balance, right? So this is the keywords which you should not forget whenever you are solving an ECG MCQs, right guys? And in exam, if you see the wide QRS tachycardia, guys, if you are completely blind, if you are not remembering anything, guys, without wasting so much of time, go and choose the option of VT, right? Ventricular tachycardia. तो बेटा जब भी वाइड QRS पूछ ले, tachycardia की हिस्ट्री दे, अगर कुछ नहीं समझ आ रहा तो बेटा लास्ट के अंदर आपको क्या मार देना है? Ventricular tachycardia, right? So these are the last minute ECG, guys. Just go before this exam, just go and check this video once again. It will take hardly few minutes to finish this video, guys, but it is going to be very helpful during your examination time, right? So guys, this is all about this last minute ECG checklist. Guys, thank you very much and the best of luck of your upcoming FMG or the NEET PG examination. Thank you very much.